usually when we talk about ligamentous injury, there's an element of trauma, there's an element of moment in time impact. So it's that more significant acute injury that we're dealing with here. So, instability, hypermobility. In the context, let's define what we're going to talk about in the context of this. So I'm going to mainly focus on anterior cruciate ligament, because that is a significant injury from the point of view that when it happens, it's an extended time of recovery. So it's less frequent, so 6.4% of all reported knee injuries, most frequently reported in sports that involve change of direction. So some sort of contact, some sort of pivoting, turning, change of direction within the sport. In this study, which was an Australian study in the high performance sports system across multiple sports, they found it highest in netball, winter sports, so we're talking your snow sports or ice sports, basketball, field hockey and gymnastics. 1/4 of the ACLs were one quarter of the ACL injuries that were reported were a second injury to the same person. So, and most of them were on the same knee. So out of the 34 that were reported, so their numbers are wrong there because 26 and 6 is 32 and there were 34 injuries. So I'm not sure what's gone on there. But anyway, out of the 34 that were reported, 26 were the same knee again. Median return to sport time was around a year. Return to sports times reduced with increasing age. So we've talked about that. We'll talk about that with return to play protocols as well. Medial collateral ligament MCL injuries are far more common. The single most common traumatic knee injury in football, and football I'm talking soccer, like what you call football, not me. The mean layoff period of time is 24 days. So there is obviously a wide range. The standard deviation was 22 days, plus or minus. But it's a more common injury, but it takes less time to recover. It doesn't mean that it's not a significant injury, and there are a grade 3 MCL is both painful and it's a long time to get back to sport. But the recovery usually is really good, and it's faster than an ACL. And in this UEFA study, so again, soccer study that we're talking about, all except 2 of those 130 injuries were managed conservatively. So usually, medial collateral ligament injuries are managed without having to require surgery and have good outcomes. And I've spoken to my friends who work in high performance, elite level Australian rules football. Even at that level, with that high demand contact, change of direction, sport, speed, they will still manage them conservatively.
Do you prescribe the brace for them?
Yeah. Initially, we'll just go through our sort of discussion around surgical management, etc. But we'll talk about that when we get to managing conservatively. Yeah. And if I don't have any notes, just remind me again. So, surgical management options, and of course we've just said that MCL generally we don't do surgery, so let's go with ACL in this case. ACL-R means repair, reconstruction. Either hamstring double bundled with a semitendinosus and gracilis graft. So as we palpated yesterday, that your pes anserinus, stripping off the distal tendon, or stripping off a portion of this distal tendon there. Bone, patellotendon bone grafts. Allografts, so a donor graft, or a remnant sparing repair, so repair of the actual ACL itself. Now, I'll be up front here, I've not seen a remnant sparing ACL. Has anybody seen that? No, where they try and repair the actual in the ACL that is torn. So I'm again, that's a 2024 paper, so it's not a common procedure. I've not seen anything clinically. I've got a clinical question to ask you though, because I've just had someone who has had a perineal tendon reconstruction. Has anybody seen that?
Not seen, but I've had a ACL patient whose doctor gave her the choice of taking a tendon from the peroneus.
Yeah.
So she chose the hamstring instead. Yeah.
Okay. Anybody else?
So what kind of surgery?
Perineal tendon graft.
Oh,
I'm seeing this client next week. He actually, I don't know why he's had this surgery. This is his second repair. The first one, his allograft failed. So the allografts have a high rate of failure.
Yeah.
Hamstring, bone, patella tendon, bone, both have equivalent recoveries. The difference being the rehabilitation of the donor site. And this particular client, he had an allograft surgery which has failed, so now he's had this perineal tendon surgery which I've never seen before, and all the that's why I thought maybe you guys might have, because all of the research I've looked up seems to be coming out of India. So I thought maybe that you guys might have seen it with your surgeons who had some idea about it. So wait till next year, I'll let you know. I just don't want his second one to fail. He says it's going really well, but I'll see you next time. So, post-operative protocols depend on the surgeon and the type of graft. Obviously, they have seen the amount of damage. It might also depend on whether they have a meniscal repair at the same time, and then they would be in a brace and non-weight bearing for a period of time, whereas if they've just had an ACL repair, they'll be up and moving and not in a brace. Is that the general consensus that you have? If there is an isolated ACL, there are crutches for comfort, but not braced, and weight bearing is tolerated. Is that right? Yeah. So it's both the ACL repair that you are managing, and you are also managing protecting the donor site. So whether it's the hamstring, whether the quads, and obviously whichever one they have grafted from is dramatically affected in its strength and is a real focus in your rehab protocol. So again, another one of my athletes who had a second ACL rupture. Her first graft was a hamstring graft. Her second one has been a bone patella tendon bone graft with the ITB what do they call it? Not tenodesis. Yeah, tenodesis, removing the tendon, essentially, to help restrain the tibia a little bit further. So, we had to rehab the hamstring part of it, and she still has to work very hard on her hamstring, and now we've got to work really hard on her quadriceps as well. So, it's interesting when you listen to research articles, podcasts, what are the actual return to play rates for ACLs at their previous level of sport? So the surgeons will tell you they do great. However, what we know, 60% of recreational athletes go back to their previous sport. Apparently 83% of elite athletes go back to their previous level of sport. However, do they stay there, and can they continue? Other studies have said it's 50%. Generally and again another 2024 paper, generally they have a reduced career length, and only 65% of elite male footballers, so again we're talking soccer, not my football, are still playing at the same level 3 years post ACLR. And 62% of female footballers quit 2 years after return to sport. So essentially they struggle with performance, they struggle with that higher level, whether it's ongoing symptoms or whether they just find that they can't perform the way that they did. And as we were talking about in a general sort of chat before, the thing I think it's important to counsel when people are having surgery doesn't really matter what surgery you're talking about, it's not going to feel quite the same as it did. So for example, we were talking about end range knee flexion tightness post ACLR. It's a common occurrence, it's a common end stage limitation that may not change. I don't think it's related to joint surface stiffness, so therefore doing a mobilisation I still think is contraindicated, because that mobilisation of the joint is how they sort of injured their ACL in the first place, and they're generally younger, they're not stiff OA yet. And when you're thinking about what is limiting that knee flexion or knee extension, if you've got limitation of a knee extension early and you can't make it move, potentially they've got a cyclops lesion, so extra bony growth in the trochlear notch, which is limiting it, and it needs to be surgically removed. So that might be one cause. Potentially that knee flexion end range tightness might be placement of the graft. It might be thickening around the in the trochlea around where the ACL is inserted in there. So there may be a structural reason that you just can't get past that last tiny bit with overpressure of knee flexion, but functionally they've got more than enough room for movement. Medical management. It is informed decision making. It involves a lot of education for people to choose their pathways, and there is a lot of chatter. If you listen to social media, there is a lot of chatter. Should you be having an ACL reconstruction? Should you not? And there will people that will strongly argue one way in both camps. So what we're, as I think responsible clinicians, should be helping people make informed decisions. It's not our decision to make. So strongly arguing only one side of the discussion isn't helping someone make an informed decision. You're just telling them what that one side of the discussion is. So our treatment pathway, we have conservative management. This is not a braced approach. This is just, let's see how you go and let's see if we can get your knee more stable. Are you functionally stable? Do you need a surgical repair? Second one is a conservative management program which is braced with the intent that the ACL ligament is going to heal. And thirdly, they can trial conservative and progress to surgical repair as they choose. And finally, there's surgical reconstruction, ACLR. So there's been a lot of buzz lately about this cross-bracing protocol. So the cross is the doctor, Mr. Cross. Professor Cross and his son, Mr. Cross, who are, that must be Mervyn and Tom, who are the pioneers of this technique. And they work out of Sydney. Sydney? I think it's Sydney, otherwise it's Melbourne. I'm pretty sure it's Sydney. Anyway, somewhere over there in Australia. And they have applied this principle, apparently, according to what I've been researching around this, they applied this principle to someone who was a young person who had ruptured their ACL. They didn't want to have surgery, or they couldn't afford to have surgery, as in they didn't have private health to cover the surgical procedure. So the surgeon, the orthopaedic surgeon went, okay, well, if ligaments heal when you push the two ends together, why don't we try holding the two ends together and see if it heals? So this is Mr. Cross's bracing protocol. So essentially, they have recently started doing research to see what the outcomes of this approach is. And they've had a 2-year follow-up. So I'm just trying to remember how many people they had in the... They've had quite a few... Sorry, I can't remember the exact number of people that they have had in this protocol. I'll look it up. But the numbers aren't huge, but they're not also just 5 people. They do have a fair bit of.
72 to 80.
Oh, thank you very much. Thank you very much. That's helpful. I was like, why didn't I write that down? Okay, so they follow these people up for 2 years after this cross-bracing protocol to see if what their outcomes are, trying to get some idea in a research way of whether this is a good protocol to follow. So, 72 out of 80, thank you very much. Participants who presented and were MRI'd with complete rupture of their ACL, so a grade 3 as we talk it, had signs of ACL healing after 3 months. So that's after they've completed the ACL bracing protocol. And this is, with the cross bracing, it is from, we'll go through the protocol in a moment just so that you can familiarise yourself with it. It's a progressive movement from 90 degrees knee flexion to 0 degrees knee extension over that 12 weeks. They reported better sport and recreational function and knee-related quality of life at 2 years, which is great, compared to those who didn't have any signs of healing on MRI. And better outcomes than people who were managed with an ACL reconstruction. Which I find interesting in a way, because a lot of the time you don't need, I'm not sure about this, because we're saying also that some people don't need an ACL, but we can function quite nicely without an ACL. So are we saying then that all people have to be repaired to have good quality of life? I don't know, I'm a little bit dubious about this one. But anyway, we'll see. And they say they still need more numbers, they need more structure, they need another RCT. They suggest delaying return to sport until 12 months after the injury to allow sufficient time for the ligament healing. So from my point of view, what we don't know still is the quality of that healed ligament structure. And these are just questions that I have. Currently they don't perform an MRI any point further down the healing pathway. And maybe they would do that if they did a different type of study. But this one they were just looking at 3 months. What is the appropriate time for return to sport? Do they want it to be, is 12 months enough? Could it be shorter? Does it need to be longer? Still again, we don't know. And we need more numbers and more patients, and we need more extrapolated long-term outcomes. Because what we saw in the other data that I was showing you, they were talking, 3 years later people stop playing sport, or the time it takes for someone to re-rupture is often longer than 2 years. So it's interesting, but they hadn't had re-rupture. I think they had one case of re-rupture, which was someone who had a contact injury, so it wasn't just a spontaneous re-rupture. Okay, so there are quite a few, if you're a podcast listener, there's quite a few podcasts out at the moment, which just talk about the bracing protocol, how it's applied, what their outcomes have been. There's one, I think, on JOSPT. There is an article, if you look at the ASPAR Sports Medicine journal, they call it. It's free online journal. They've got an article on it as well. So there's lots of resources out there if you want to listen to people talking about in a more informal way than the actual Canon trial, to give you some information. But essentially what they're saying at the moment, this is not a protocol you can do anywhere else at this stage. You can only do it in this centre. They are currently training orthopaedic or sports doctors, orthopaedic surgeons up in the protocol, and they're currently training physiotherapists up to deliver the protocol and the rehabilitation protocol over a period of time. So what we've got here, this is the cross-bracing position. 90 degrees of knee flexion, and you're held in this position for the first 4 weeks. So you can have a look at that, and you can see that's quite restrictive, isn't it?
Yeah.
So one of the things that they said, I think in one of the podcasts I was listening to, they often do more left legs than they do right legs, because you can't drive if it's your right leg, but you can drive if you've got an automatic car and it's your left leg. So they're finding that people are saying yes if it's their left leg and not if it's their right leg. So you can also appreciate, this is not a you can take it off to shower. It is on 24/7. So there are some people that this would not be appropriate for first of all, medically. So people who are prone to clotting, or who have had any history of clotting, or have any comorbidities that suggest that might be something that could happen for them, would not be eligible to this. And they have to take blood thinners while they're on this as well to avoid clotting. Socially, people have to be able to cope with that. Imagine trying to manage that if you lived in stairs. That would be tricky. People have to be able to cope with it mentally too. It would be a long time. When that's your lived experience, that's a long time. So they do a lot of counselling and they do a lot of explaining of what the protocol is before people go towards this. There's also a time frame. Ideally, they need to be seen and in the brace within 10 days of their initial injury. So it's quite a niche selective process from both a biopsychosocial approach and from a timing of when you present to the orthopaedic surgeon.
This is someone after they ruptured their ACL?
Yes. Yeah, so this is one of their clients. So they're saying, no, well, their protocol is that brings the ACL together.
What if it's too short?
I don't know.
Now you have no complete extension.
Yeah, well, imagine how much work you've got working on their knee extension.
Yeah.
That would be hard work. So, I'll just run you through the protocol so we can have a look together so you've got a bit of an idea. But this is not something that can be managed with physiotherapy alone, because you need to have that medical management of their risk of basically, their risk of getting a clot. So, they've got week 1 to 4, but essentially from the moment you're in the brace for the first 4 weeks, that range of movement brace is fitted and locked at 90, and you're non-weight bearing. So you can weight bear, so in that position she was on that scooter, you can weight bear through your femur, but you can't weight bear through your foot. The DVT, risk mitigation, is your number one thing. So you're on anticoagulant at this period of time. Lots of counselling regarding the anticipated discomfort. No anti-inflammatory medications. And no drainage of the hemarthrosis, because obviously now you're on anticoagulants, so you would be a bit of a problem. Rehab exercises, everything that you can do that doesn't involve that knee, essentially. And you can also see they do want you quads and hamstring co-contraction. They do want some plantar flexion, dorsiflexion against resistance. And they do want some hip work because they want everything that's going to keep that blood circulation going, but that plantar flexion and that quad hamstring as much as they can. After 4 weeks, they can move to 60 degrees of knee flexion, and they're still on the anticoagulants. They're trying to continue with similar exercise, so that doesn't change very much yet, because they're still at 6 weeks, week 5, 60, week 6, 45 degrees. Now they're getting a bit straighter, but they're still in the brace all the time. 7 and 8 weeks, you're going 30 to 20, and then at 10 weeks, you have 10 degrees, 9 weeks you have 10 degrees, 10 weeks you have 0. So,
when you're allowed to move in that range, So at 6 weeks.
Yes, you can.
So you can move from 45.
Yeah,
to
you
90.
can move 60 to 90, 45 to 90. So you're starting to get a little bit more exercise and movement. But interestingly, they still, and I don't have the detail on this, I don't know if they can move 60 to 90 or whether they can go in 60 and then they're going to go in 70 and they go 80 and 90 and do co-contraction at varying angles. I don't know. I haven't, in Perth, I haven't seen anybody that's had this sort of protocol. Okay, so it is, like you said, it's a range. It looks like, you can move 30 to full flexion, 20 to full flexion. It sounds like it. Okay. So at this, when you start to get to that 9 to 10 weeks, things like overcome the aims is in this column here. Overcome anticipated fixed flexion contracture. So you're working hard on the soft tissue that is tight to regain the extension strength, range of movement. But at 10 weeks, you can then wean off the crutches and you can be full weight bearing. You're still in the brace. Unrestricted range of break till 12 weeks, and at the end of 12 weeks, you can take the brace off. Imagine that day, you'd be so excited, wouldn't you? And then you start your progressive rehab program as you would normally. So it's it requires a lot of buy-in by the person, and they do have shortened protocols. I think they have a 6, or maybe it's 8-10 or 6-10-12 protocol. The podcast is with, might be Steph Philbay that was talking. I think it was. She was saying that most people go for the 12-week protocol because they figure if they're going to do it, they might as well give it the best chance to do. So most people go for the 12-week protocol apparently. And then obviously they're progressing. So at 16 weeks, they're suggesting now you're trying to run. So, interesting. And I don't have any feedback that I have in any real life experience. Their criteria to commence slow running is that they have to have at least 80% strength, quadriceps and hamstrings, which fits absolutely. I agree. But I'm interested, they've only been out of the brace for 4 weeks. To be able to get up to that strength would be impressive, what I would say. They must, while they said introduce running, they stipulated they must meet some running criteria. They can't just go and run. And there's your progression history there, okay? Their criteria for return to training, same as everything else. There's no difference in that. So that article is the BJSM article with the heading that I gave to you before. I think it's open access if you don't have access to the journal articles, but I think that one is an open access article. So, if we're talking now generally, and also the ACLs that I work with are either conservatively managed, no surgery, conservatively managed, go to surgery when at a time of their choice. So like we were talking about the total knee replacement, people can choose to delay their ACL reconstruction. It doesn't have any negative effect on their ACLR outcome. It also has potentially a better outcome because they have prehabbed their knee. And the disappointing thing is by the time they go for surgery, they're actually feeling quite good. And they're like, oh, I've got to start this again. But they tend to bounce back a little bit quicker because they've got that prehab on board. And the research also says they tend to have better outcomes. I work with people who have allograft occasionally, failed allograft. ACL hamstring, ACL bone patella tendon bone. I have not worked with anybody who's had a quadriceps tendon, and I have a new client with a perineal tendon. So that's my caseload. I've got quite a few different people. I've got an ED doctor. She had one knee reconstructed, and that was okay. She ruptured her second one, contralateral leg. Quite a few years later, I saw her for this one. She wanted to manage it conservatively because she had too much going on. Life was too busy. She didn't have time to go and have surgery. And she's probably had an equivalent outcome. She's back running. She doesn't want to go back playing netball, which is how she hurt her knees. She doesn't want to go back and do that, but she's been on skiing holidays. She's been running back at the gym. She's got busy work and busy life. So they're the types of people that I work with. So from recreational through to elite level. So this is my take, my interpretation of all the research and what I do. So first of all, from a physiotherapy management, we are looking if we can have that interface to try and introduce primary intervention, as in we are trying to prevent that injury happening. Education is a cornerstone of ACL management, whether it's in a prevention space, obviously as a tertiary space on the other side of the injury, and what they do next. Building confidence around someone who's had an ACL injury is really important, however they plan to manage it. Manual therapy, and I'm talking about tape for stability here, that's rather than mobilisation, because we're already saying we're trying to stabilise everything. So we will go through tape for the MCL, and I'll show you some strips that you could apply for more rotational control. Exercise is the cornerstone, and load management and progressive load back to activity is key. So, injury prevention. It's really difficult to pick who will injure their ACL. So they've actually done studies where they've got people to do like a drop landing, single leg, and looked at their biomechanics, and some people land poorly and some people land great. It doesn't predict who's going to do their ACL, who's going to injure their ACL. They've done that in a research cohort following collegiate athletes in America. Injury prevention programs reduce lower limb injury. They do work. 53% reduction in ACL injury and a 67% reduction in non-contact injuries in female athletes. Now, the only problem is people have to do the exercises, and what they've found the biggest problem with getting these results is people adhering to the programs. So if you're involved in a team which has a change of direction as part of the sport, it would be great if you can get that education out there and try and implement these programs. It is an intervention that is applied to everybody, because there's nobody that's going to find this intervention harmful, and we can't predict those that are going to need it. So we're trying to apply this intervention to all. And primary prevention are those interventions that can have benefit to the whole population. So in the case, we first were talking about it around disease prevention, for example. So that might be vaccination, or it might be for breast cancer, mammography screening, so that you can have an intervention that improves health for everybody. They need to be done for at least 20 minutes per training, for a total of more than 30 minutes per week. So it needs to be integrated into the training protocol. It just needs to become part of what they do. So FIFA 11 Plus is a very prominent injury primary prevention program, freely available on the internet with training protocols and videos. In Australia, we've got one for netball. We have one for Australian rules football. I know there's also one called Set Go. Oh gosh, it's orange. Released by the International Olympic Committee, and it has all sorts of sports. And that one has badminton and handball and all sorts of sports with exercises and prevention exercises that you can do. So it can give you ideas for what you might do with your athletes too. If you're looking for exercises, they're great resources to look at what you could implement. There's a Dutch field hockey one. So there's a lot of different programs out there and free resources online because people are keen to get that information out to be used. Education. Set their expectations early. They need to know what is the return to play timeframes, what is the recovery process, what is it going to involve from them, both physically, how much exercise they will need to do, things like that. They may also be quite cost sensitive. People need to know how much investment they are making in this too. The difficult thing in the Australian system that we have is that doing private physiotherapy over a 12+ month period to fully complete your ACL rehabilitation can be expensive. And so people potentially think that having a reconstruction is an easier option because in private health, they cover everything. They still have to do the rehab on the other side of that, so it doesn't actually change the cost. I think explaining what a treatment timeframe might look like, and I think this also helps in any sort of condition when you've got private pain particularly, just set cost expectations, is in the initial stages you've got to get them moving, you've got to get them going. In the initial 3 months perhaps it's more intensive. But then you're going to get to a point where you're going to be like, right, this is your work for a month, off you go. This is your work for 6 weeks, off you go. This is your work for the next. And you just titrate it to when it's important time points where you want to progress. But in the early stages they're going to be progressing quicker. Then they get to the middle stage and it sort of slows down. And then they're going back to sport, and that's where you want to keep an eye on them a little bit more again. So if you just can explain what your plan is for them, I think it helps the buy-in for that extended period. People get rehab fatigue, so set it up early. What I think we find for a lot of people who are not supported financially in an elite system or a system where their costs are covered is that they get tired and they tend to drop off at about 6 months. And they don't necessarily finish the markers off to finish the rehab protocol to hit those KPIs to safely return to sport to give them the best chance of not being in that 25% of re-rupture. Return to play timeframes, 9 to 12 months for adults. If someone is in the younger age bracket, I would say 25 or younger, or is a second ACL injury, it's more than 12 months. MCL grade 1 to 2 is sort of 2 to 6 weeks. A grade 3 can be more than 3 months recovery. It's a significant injury. It's an active recovery process and it is KPI driven, milestone driven, rather than time driven. So while I might have an indication for both of those pathologies, if they haven't actually achieved the KPI to progress, then it's going to be delayed. And that may be delayed by someone who also, then a meniscal injury pops up, or they go on holiday and they drop off their exercises, or they lose momentum and then they have to come back to it. Things happen along the way, the recovery journey is not always smooth. Again, this is another BJSM article for the Aspetar ACL rehab protocol, another resource for you to be able to dive into if you want to explore different thoughts or different ways of explaining it, just to give you an idea. So let's do some taking. Let's get right.